our facilitator for today's session, Dr. Simon Hughes of the Guy's and St. Thomas's and NHS Foundation Trust. He's our session facilitator. He's also the chair of the International Education Steering Group at ASCO. Welcome, Simon.
Thanks, Vanessa, and good evening to everyone from London, UK. I'd just like to thank the organisers for this invitation to act as the session facilitator for this research meeting. As Vanessa says, I'm a clinical oncologist at Guy's and St Thomas's in London, and I specialise in the treatment of bladder and prostate cancer. So it's quite humbling to see how restricted my field of expertise is compared to probably most of the people on this call. I'm also very much looking forward to learning from our expert faculty today, and also insights from our expert participants as well about sort of research and how to manage research in an African setting. Last week you had a session on epidemiology of cancer in Africa, and today's sessions, this is session 2 of 6, is how to evaluate medical literature and evidence-based medicine. So these are our faculty. Next slide, please. So that's me on the left. And then the course director, Professor Ian Tannock from Princess Margaret Hospital, who's a professor of medicine and medical biophysics. He's also probably best known across the international oncology community as the author of the seminal textbook, Basic Science of Oncology. I think most oncologists around the world have a copy of that in their house. I've actually got 2 copies in my house because my wife's an oncologist as well, so she also bought one when she was a trainee. And then we also have Dr. Kile Manirakiza, who's a consultant clinical oncologist in Rwanda with a strong interest in clinical trials. And as I was saying earlier, I specialise in bladder and prostate cancer. He specialises in CNS tumours, head and neck tumours, breast, gastrointestinal tumours, genitourinary, skin and sarcomas. So that really puts me to shame. So these are our expert faculty today. And next slide, please. This is an overview of our agenda. So we're just going through the overview now. We'll then have 30 minutes with Ian on how to evaluate medical literature and evidence-based medicine with a question and answer session afterwards. And as Vanessa said, if you can submit your questions on the chat function, then we'll try to address all the questions in that session. Then Dr. Kile gives us our research presentation for 15 minutes, followed by another Q&A session. And then we've got the main feature is a breakout session, 45 minutes, where we've got a workshop where we'll be working through some research questions, and then a debrief at the end before closing remarks. So this is a 2-hour meeting. So we're aiming to finish at sort of 8 p.m. Greenwich Mean Time or Côte d'Ivoire time as well. Actually, being in London, we're 1 hour ahead of Greenwich Mean Time if anyone's interested in that. So anyway, next slide, please. So these are the goals for this session. And I think whilst you're listening to the presentations and taking part in the workshop, try to keep these in the back of your mind. So at the end of this session, we want you to be able to evaluate critically published clinical trials for cancer, determine the clinical value of new treatments, and then recognize strategies that could be applied in environments with limited resources. So these are our goals, and I think these should be guiding your thoughts and your reflections through this evening's meeting. So I'm going to hand over now to Professor Tannock to take you through how to evaluate medical literature and evidence-based medicine. Thank you, Ian.
Thank you, Simon. I'm very happy to hear that both you and your wife have got copies of our book, which has just come out in the 6th edition. I'm going to try and share my screen. Let's see if this works. I think there's hope. There we go. Can you all see the screen?
Yes.
Okay. So we're going to talk for the next half an hour or so on this topic. And please think of questions you'd like to ask me at the end. I don't think I have any conflicts of interest. I tend to stay away from far more organized events, particularly marketing events and things like that. Although I do sit on and have chaired some data safety monitoring committees, some of them academic, which is voluntary, and some for companies where I am reimbursed for my time. So just a couple of slides on trial structure. I suspect most of you are familiar with this. And in the development of drugs or other treatments, including radiation or surgical treatments, generally clinical trials go through phases. They are being modified, but phase 1 trials are essentially to evaluate toxicity, and if you're looking at a new drug, to look at its disposition, its pharmacokinetics, and to determine the dose that would be suitable for use in phase 2. Phase 2 tends to look at specific types of tumors and increasingly specific types of tumors with a given type of characteristics, pathological or by mutation. So they are aimed at seeing if there is sufficient evidence of anti-tumor effectiveness and defined toxicity. But anti-tumor effects is not the same as benefit to patients. That comes in phase 3, which are usually randomized trials where a new treatment is compared with the usual standard of care. And then subsequently, after registration and approval of drugs, there are additional post-marketing survey assessments, sometimes called phase 4 trials. And these can be very important to pick up unrecognized toxicities in wider populations, less selected than those in the trials. So phase 1 and phase 2 trials really are generating hypotheses. They're asking, is there enough evidence to study this treatment further? And drug development is like a funnel. There are many ideas coming from the lab, and gradually as these new agents are tested, only a small proportion of them ever get to be tested in phase 3 trials to ask about benefit to patients. The endpoints or outcome measures of phase 2 trials often include tumor response. Does the tumor shrink? Is there a biomarker response? If you're dealing with prostate cancer, does the PSA go down, for example? They indicate anti-tumor effects, but it's important to recognize that this is absolutely not the same as benefit to patients. And there's very limited correlation between the ability to shrink a tumor and the ability to improve the survival. It's phase 3 trials that can change treatment. And there's really only 2 goals of any medical treatment, whether you're a radiation oncologist, a surgeon, whether you're a nephrologist or a cardiologist. You really are aiming to either allow the patient to live longer and or to allow the patient to have a better life, to live better, to have a better quality of life. And hence there really are only 2 ultimate endpoints of a phase 3 trial: overall survival and or quality of life. But we're faced in the oncology literature where many supposedly surrogate endpoints are used, and we need to look at those critically. So everything I'm going to say from this point on relates to phase 3 trials where the aim is ultimately to change treatment. And here are some of the questions that you should ask about phase 3 clinical trials. Obviously, the first one is, does it ask an important question? We have many trials that are, if you like, asking about Me Too drugs, docetaxel versus paclitaxel, that aren't terribly interesting. And whereas we need to look at more fundamental trials about different and new treatments compared with older ones. We should ask if the control group is appropriate. I'll give you an example in a moment of a trial where I don't think that was the case. And if you start off with a control group that is not the standard of care, then you can make a new treatment look better than it really is. Ask if the primary endpoint is a measure of clinical benefit. If it's not, particularly if it's not overall survival or quality of survival, then ask if the endpoint that is used actually is a predictor of those 2 important endpoints. Is toxicity evaluated and reported well? I'll show you that often it is not, it is underreported. And does the report of the study truly reflect its results, or is it reported with bias? And it's important that as you read the literature, that you be able to detect bias when it occurs and recognize when treatments are reported appropriately. Are the outcomes of clinical value? That's quite different to statistical significance, as we'll talk about a little later. And finally, will the results apply to patients that you see in your clinic? Recognize that patients going into clinical trials are quite highly selected, so they may not represent the patients you see. And here's a paper that I wrote with several colleagues and former fellows. It is about 5 years old, but I think still relevant to looking critically at randomized controlled trials. And I asked Vanessa to circulate this. Now, some randomized controlled trials have an inappropriate control. The control should be a standard treatment at the time that you're looking at a potential new treatment. Sometimes you can have more than one standard treatment if you use different treatments in different parts of the world, but each of them should represent the best that is available at that time. Now, here's a recent paper. It actually had 2 publications in the New England Journal using olaparib, which is a DNA repair inhibitor, a PARP inhibitor, for metastatic castrate-resistant prostate cancer. And the trial compared olaparib, which of course is very expensive, to abiraterone, a hormonal agent used after enzalutamide, a different hormonal agent. When you had progression on one, you used the other. And it was specifically for men with prostate cancer who were shown to have defects in DNA repair. The primary endpoint was imaging-based progression-free survival. And you can argue whether or not that is going to predict for overall survival, but in the follow-up, there was a difference in survival between the control group and the experimental group. And of course, the company that markets this is very enthusiastic to get people to use this expensive drug. And of course, you have to do sequencing to start with, which makes it even more expensive. But the problem is that the control arm in this study, which is called PROfound, is inappropriate. We already know that responses to abiraterone after a man has received enzalutamide are rare, and vice versa. They're in the single digits. And many of the men in this trial hadn't received standard treatment with docetaxel, or if they had docetaxel, with cabazitaxel, both of which are types of chemotherapy that have been shown to improve survival. So this, in my view, is a rather flawed trial. Other trials, as I say, can use a range of acceptable controls, but you need to look carefully and ask the question, is the control in the trial that you're looking at, is the control group appropriate and representing a prior standard? Now, many of the trials in oncology don't use overall survival as the primary endpoint. They tend to use progression-free survival. And I think there's a big problem with using progression-free survival. It's rarely a surrogate for overall survival. You may delay progression, but then subsequently, there may be other treatments that allow you to maintain survival. And if you do delay progression, that's often at the expense of toxicity. So the value of PFS, or progression-free survival, depends on a balance between the toxicity that is added and improvement or delayed symptoms. Obviously, patients like to be told that their tumor is not progressing, but if that's achieved at the expense of toxicity, that's not a great gain. So improvement in symptoms cannot be assumed to dominate added toxicity. It's important, if you do use this, to ask if there is better quality of life, but as we'll come to, that often isn't done or isn't done very well. And progression-free survival is especially subject to bias when there is uneven dropout between the arms of a trial. That's known as informative censoring. And if you have 2 randomized groups, and perhaps because of toxicity of a new agent, those in the experimental group drop out early, before they have progression, they're not regarded as failing the treatment, they're just censored, then you have a bias because you're comparing a control group with a selected group from the group that have received the experimental treatment. And I'll show you an example of that. And we wrote an article about this recently that appeared in Nature Reviews, Clinical Oncology. So here's an example. This was a trial led by Jose Baselga, who unfortunately died recently, looking at the drug everolimus for hormone receptor positive advanced breast cancer after they'd been treated with standard hormonal treatment, tamoxifen, or a non-steroidal aromatase inhibitor, and published in the New England Journal with these curves that looked at progression-free survival for everolimus plus the steroidal aromatase inhibitor exemestane versus exemestane alone. And there's a very impressive difference between the experimental treatment and the placebo plus exemestane. However, if you read the relatively small print in the paper, there was early stopping due to adverse events with everolimus, either or withdrawn consent, which is usually because patients are doing well, in a quarter of the patients, 24% of those on the experimental arm. So they weren't regarded as failing the treatment, they were just dropped out, and only 6% in the control arm. And so that leads to a bias. Patients who withdraw from a study for toxicity or other reasons are censored if there is no disease progression already occurring. And that can lead to a false result. And when subsequently the survival results of this trial were published, those are the two curves, and you can see that there is really no difference in survival from adding everolimus, which is a fairly toxic drug, to these women with breast cancer. So I think you weren't really achieving anything, and yet this was used to market that drug and has been used to market many other drugs. Now, I have a bit of a reputation of being a cynic. I prefer to use the word skeptic, but this to add some humor for you. What should we call an agent that increases progression-free survival, has no effect on survival, doesn't improve quality of life and adds toxicity? And I think the answer is harmful. And yet, despite that, many drugs have been approved by the United States FDA and the EMA in Europe just on that basis. So here is my humor. What does PFS really mean? Well, I think it means a planned flawed study. Pharmaceutical companies will plan such studies if they can get away with registering drugs on that endpoint. And if it's endorsed by the FDA and the EMA, which it is for some disease, including breast cancer, it will lead to profit for sponsor different PFSs. Now let's change topic a little bit and talk about the reporting of harm. This is Bastian Saruga, who was a former fellow with me in Toronto for 3 years, now back as an oncologist in his home country, Slovenia. And while he was working at Princess Margaret, he did a number of studies to look at adverse drug reactions of targeted anti-cancer agents, and was a senior author on another paper in Lancet Oncology that looked at the underreporting of harm. And the problem is that when the results of randomized clinical trials are published, they usually have short follow-up, and they're usually applied to highly selected patients who don't have other major medical problems than the cancer that is being treated. And what he found was that all targeted agents had toxicity, that of course is well known, and patients experience more toxicity than is reported by doctors. I'll come to that. And there is substantial underreporting of toxicity. What he found was that almost 60% of potentially fatal adverse events are not in the initial FDA drug label, which depends on short follow-up in randomized controlled trials, and 40% were never reported in a randomized trial. They only become apparent when patients and doctors report this toxicity to the registration agents agencies as the drugs are used in everyday clinics. So toxicity is higher when drugs are given to less selected patients. So you should always expect more toxicity when you apply the results of a clinical trial to the patients you're seeing in your own clinics. And here is some work by Ethan Bosch, who has been a great champion of patient-reported outcomes in terms of toxicity. And this is from one of his papers from a few years ago now, where for patients who are receiving mostly chemotherapy over time, what he looked at was the reporting of clinicians, doctors and nurses, those are the blue curves, and the reporting of patients when they're asked to fill this in anonymously. They were simply questioned by doctors and nurses, and you can see that's the brown or orange lines, and the patients are experiencing much more toxicity than is being reported by doctors or nurses. And for the same reason, the performance status evaluated by a clinician is not a good measure of patient-reported quality of life. Measures of quality of life are actually prognostic of outcome independent of performance status. Now, what about quality of life? Despite the fact that the goal of many trials is palliation, virtually all the trials we do on people with advanced incurable cancer, the aim is to improve their quality or duration of survival. A lot of that is aimed at relieving symptoms and improving quality. But despite that, very few phase 3 trials have included quality of life or patient-reported outcomes as a major endpoint. And when they have included them, they've often used what is, in my opinion, a flawed type of analysis. We wrote a paper on this a number of years ago, and it's time that we updated that. Now, how should you and how should you not evaluate quality of life? Well, what we found, if you look at published randomized controlled trials where there is assessment of quality of life, and it's often reported as secondary endpoint and separately, what they tend to do is to measure the mean quality of life score of each randomized group at baseline and then at a later time. So each patient fills in a quality of life questionnaire, and that's averaged over the group, both to begin with and later. And they then compare the mean scores for each arm at a later time with the baseline. And of course, the problem there is that patients will drop out, so you don't have the same database, and they'll compare the mean scores of arm A and arm B at the specified time. Why is this bad? Well, if you think about it, when you treat patients with, say, a new treatment, some of them will respond and get better, and some will get worse. And so what does mean quality of life mean? If you average those getting better and worse, it's not telling you anything. It's like as though you average tumor size instead of measuring the proportion of patients that respond in terms of tumor shrinkage. What we should be doing is reporting the proportion of patients that actually have an improved quality of life. So the better way of doing it is to recognize that quality of life is a property of an individual. And for appropriate analysis, you should record a relevant measure of quality of life repeatedly for each patient. Now, what that measure is will depend on the disease. In our studies of prostate cancer, where bone pain is fairly dominant, we used a patient-reported outcome of a pain scale. You can determine the change of that endpoint that's clinically important, and generally a change of more than about 10% in a normalized scale, that's a scale going from 0 to 100, is clinically important. And then you can determine the proportion of patients with improved quality of life that receive that treatment. And that's the way that we evaluate it, for example, improved pain in patients receiving a treatment for metastatic prostate cancer, and you can measure its duration. Moving on to actual reports of clinical trials, it's important to recognize that there is bias in the clinical literature. And we've actually done studies with a French group showing that there is bias in terms of how how papers and abstracts are presented. So just a few guidelines. Many of us are very busy, and for many papers, we probably only read the abstract and skim the rest of the paper. So first of all, the primary endpoint, and all randomized trials should have one primary endpoint. Very few of them are big enough to have more than one endpoint, and ideally that should be overall survival, and if there are two, it should be overall survival and quality of life. It should be defined explicitly in the abstract of the paper or the presentation at a major meeting like ASCO or ESMO. That primary endpoint should reflect benefit to patients. The concluding sentence of the abstract should relate only to the primary endpoint. It shouldn't use secondary endpoints to make something look positive when the primary endpoint was not benefited. And the abstract should include a statement of major toxicity. So these are fairly simple, straightforward guidelines that you would think the editor of any major journal would ensure were satisfied. But despite that, many reports, both in high-level journals like the New England or JCO, and at ASCO and ESMO meetings, do not meet these simple requirements. This is another former fellow. This is Francisco, or Paco, as we call him, Vera Badillo, who is from Mexico, but now is at the Clinical Trials Group in Kingston, Ontario, the Canadian Clinical Trials Group. And he undertook some studies of the quality of reporting. This was one of his studies looking at all the randomized controlled trials for breast cancer published in that 15-year period. And what he found was that about 2/3 of them showed no significant difference in their primary endpoint, and about 1/3 did. Now, in those that didn't find a difference in the primary endpoint, more than half of them used a concluding statement of the abstract. Instead of simply saying we didn't find benefit, they used a secondary endpoint to suggest benefit, or a subgroup analysis. So this is immediately introducing bias. Only 1/3 of the abstracts indicated the frequency of severe toxicity. And if you had a positive result for the primary endpoint, that was associated with underreporting of toxicity, as though, well, we've got some benefit, and it might have been progression-free survival or overall survival, and so we'll downplay the toxicity. And honorary and ghost authorship was common. Honorary authorship is where a thought leader is given the job, often as being the primary author. You will notice that there are some key individuals in Western countries who are very frequently first authors, much more frequently than they will have had time to really put in the effort to deserve that position. And ghost authorship is where the paper is being written by somebody who is not an author. I'll come to that. And other studies by Paco have found that this isn't just in breast cancer, it applies to other malignancies published in leading journals. So do beware of subset analysis. Clinical trials are usually powered to analyze the whole group, and subgroup analysis can lead to false results. Here's an old example. In the original trials that showed that 5-FU and levamisole was effective adjuvant treatment for Duke C colon cancer, in the Mayo Clinic trial, it was found to be more effective for men and older patients, and in the Southwest Oncology Group trial, more effective for women and younger patients. Now, of course, neither of those statements is true. Both of them showed there is a small but significant overall effect, and by looking at subgroups, you're simply looking at variability and can lead to false results. And there's even been papers looking at the outcome based on the sign of zodiac under which you were born, which obviously is nonsense. Ghostwriting. Well, this was brought home to me when I was looking at the abstracts published in the virtual ESMO meeting from last year, 2020, and I looked at those initially for the diseases that I'm interested in, GU cancer and breast cancer, and then I looked at all the phase 3 trials, and I noted that 80% of these abstracts that were reporting pharmaceutical-sponsored phase 3 trials acknowledge writing assistance. What writing assistance really means is that the pharmaceutical company employed a medical writer to write the abstract. And the abstracts are only about 350 words. So I think this is terrible that the investigators would allow this to happen. And then I went to the New England Journal, looked at 3 months. I think that was September through November. And there were 21 reports of randomized controlled trials sponsored by pharma in that period, and 16 of 21, so again, close to 80%, were first drafted by a medical writer. At least New England and Lancet requires that to be stated, but I don't think it should happen. And while some medical writers might draft unbiased reports, they are employed by or contracted to the sponsor. So there is substantial potential for biased reporting. If you think about it, I mean, some of us, may have kids, or my stage, even grandkids in university. If they handed in something that was written by somebody else, they get thrown out. And yet we accept this from investigators. And I think we should stop doing that. Now let's talk a bit about the difference between statistical significance and clinical value. There's a recent statement by the American Statistical Association about p-values. There was a publication that references there, and it's also on their website. And basically what it says is p-values do not measure the probability that a hypothesis is true. Scientific conclusions and policy decisions shouldn't be based only on a p-value of less than 0.05. A p-value doesn't measure the size of an effect or the importance of result. If you have a tiny difference, if you include more and more patients, you'll get a p-value of less than 0.05, but that doesn't make the difference important. So by itself, a p-value doesn't provide evidence regarding a model or a hypothesis. And yet it is precisely the p-value that is used by, influential journals like the New England to accept a paper. Usually they don't publish many negative large trials, and by the FDA and the EMA to register a drug, no matter how small the effect. John Ioannidis has written quite a bit about this. Here's one of his rather cynical papers about why most published research findings are false. He said that simulations show that for most study designs and settings, it is more likely for a research claim to be false than true. And that's true of clinical trials. And what he's really saying, and the important thing here, is that the important test of the validity of a clinical trial is not the p-value. It is the clinical value of the effect, which obviously depends on the endpoint and the size of the effect, and also whether it's reproducible, that you can be misled by single trials. So let's talk a little bit about value. ESMO, ASCO, and the NCCN have all introduced value scales, and these are very important. They were introduced a few years ago. ESMO has continued to push for this to be used, much less at ASCO, I'm sorry to say. So they have different scales that they emphasize improvements in the duration or quality of survival. And so the ESMO scale uses two different questionnaires for curative treatments. That would be, say, adjuvant treatments added to surgery or radiation therapy, and non-curative or palliative treatments. And they rate studies on the basis of some questions about improvements in survival, improvements by how much. If survival isn't improved, you get less of a score from potential surrogate endpoints, and they look at toxicity, etc. So it's not rocket science. And basically for curative treatments, those trials which satisfy levels A and B are regarded as of good clinical value, and for non-curative, those at levels 5 and 4. So Joey Del Paggio, working with myself and more with Chris Booth, looked at whether contemporary randomized controlled trials actually meet ESMO thresholds for meaningful clinical benefit. So he looked at a large number of trials for breast, non-small cell lung cancer, colorectal and pancreas cancer, published in that 5-year period of 2011 to 2015. About half were positive for the primary time to event endpoint, but only 30% of those positive trials, not of the total, but 30% of the positive trials met the ESMO threshold for clinical benefit. The others had a p-value less than 0.05, but they did not meet that threshold. And indeed, many of the randomized trials were designed to detect or exclude differences in outcome that didn't meet the ESMO threshold. As far as they were concerned, if they got a positive p-value, it would be enough, and it often was enough for the FDA and the EMA to license their drugs, even though they did not satisfy criteria of clinical benefit. That was higher for trials with curative intent, and that makes sense, because even a relatively small improvement in the potential for cure is important, whereas it was true of less than 1/5 of those with palliative intent. I don't have time to go into the different schemes, but the NCCN has a relatively simple way of assessing the clinical benefit. Basically, they look at efficacy, safety, quality of evidence, consistency of evidence, and consistency is very important, and affordability and cost is very important. And panel members score each category for a given trial, 5 being the best and 1 being the worst, and then they add up those blue blocks to indicate some idea of whether this is a useful treatment or not. It's simpler than the other schemes, although it doesn't look so consistently at the outcome measures that are so important. Then moving on to talk about selection bias in clinical trials. Eligibility criteria for most trials have become more restrictive. There are some exceptions, and particularly trials undertaken in the United Kingdom that Simon and colleagues are involved with can be very open. If you think the patient might benefit, you can put them in. But a recent survey has shown that 80% now of randomized trials are run by pharmaceutical companies, are sponsored by pharmaceutical companies, and they use highly restrictive criteria. And patients in these clinical trials are selected to have high performance status and minimal comorbidity. Older patients are often excluded. And obviously that's not the same as the patients that you go and see in your clinic. So randomized controlled trials have become less representative of cancer patients treated in routine practice. And that difference between what you get in a trial and what you get in your routine clinics is being called the efficacy effectiveness gap. This is another of our former fellows, Arnoud Templeton, who's now back in Switzerland, and he wrote about this efficacy effectiveness gap. Here's one example. This relates to what we'll hear later from the treatment of docetaxel chemotherapy for prostate cancer. And in the TEX-327 pivotal trial, there were 335 men who received the standard dose of docetaxel and prednisone for metastatic prostate cancer. And the average survival of those patients was 19 months. And septic neutropenia was in 3% of them. Whereas in the routine practice at Princess Margaret Cancer Center, we looked at those men who'd received full dose docetaxel, all patients. There were a similar number, over 300 over that period, but their average survival was only 13.6 months, and almost 10% had septic neutropenia. The same doctors who were entering patients in the trial, it's simply that these patients had more problems. And a better paper, or a wider paper, was published just recently by Angela Green in JAMA Network Open. And this is just one panel from what she looked at. And she compared more than 11,000 participants in clinical trials with more than 9,000 people in the United States who'd received Medicare. And Medicare patients are those who are 65 and over, but treated with the same drugs that have been approved in the trials. And she looked at the median survival. And what you got in the trial is shown by these blue bars here. The prostate cancer, axitinib for kidney cancer, everolimus for breast cancer, and you can see that whereas what you got in the Medicare patients was much lower survival. Is the
Hi, Dr. Tanek. I think you're having some connection issues. Yes. Oh, there you are. Hi.
Is it connection issues, or is it us overloading the system with our videos on?
We usually don't have a problem, so hopefully it'll be fixed. I can see Ian is back. You're on mute though.
How much did you lose?
Not much, just the last slide.
I'll just go over the last slide again.
Thank you.
So what I was saying, I think the problem is that both my wife and I are on Zoom calls, and it's taxing the internet. So what I was saying is that we have this efficacy effectiveness gap, that patients are highly selected to take part in trials. They're younger, have higher performance status, they exclude comorbidity. Efficacy is the benefit of a new treatment in the clinical trial. Effectiveness is the benefit of a new treatment in the real world. So patients treated in your clinics will have less benefit and more toxicity than those treated in clinical trials. So coming towards the end, you should recognize that randomized controlled trials give you some useful information. They obviously have the benefit of precise measures of efficacy under ideal conditions, but they have limitation. They don't estimate the effectiveness in the general population. There are problems assessing toxicity under real life conditions, and they can't easily evaluate uptake of treatment in the general population. For that, you need population-based studies based on registries, hospital records, and so on. The problem with population-based studies, it's difficult to eliminate bias and confounders of effect. If you compare those getting one treatment versus another, in a registry, you don't know the underlying reasons that those treatments were chosen. So this paper written with Chris Booth, who's seen here, is really saying we need to do both. So in finishing, just a word about how to generate your own research. Many of you are working in situations where you don't have a lot of resources. You have patient resources, but you don't have dollars or whatever your local currency is. But you still can do research. And much of the work done by fellows who came to work with us was done without external funding. And I think the important thing is when you're seeing patients, when you're on rounds, to write down your ideas or put them into your smartphone when you think about them. This actually was a book given to me a few years ago by one of the fellows, and that lady over there is from Vietnam. I taught in Vietnam a couple of times. My clinic list was there, and I used to write down ideas in this book, which has the face of Oscar Wilde, the playwright, on front of it. Now we all have smartphones, and you can put your ideas in your smartphone when you think about them. So when you have a good idea for a research question, briefly review the literature, see what others have done. Write a one-page summary describing the question you want to address. Show it to your colleagues and mentors and ask them to critique it. And if it still seems a good idea, write a short but fuller plan, do the research, and publish it. And just in finishing, here are some clinical questions, among many others, that have been addressed by fellows that came to the Princess Margaret Cancer Center, where we have a very full fellowship program. Do patients receiving chemotherapy have cognitive decline? One of my former fellows did work on that, and it's now become quite a large area of research. Is toxicity of new agents well established from trials? I showed you examples of that. Do patients in everyday practice have similar outcomes to those who receive the same treatment in trials? I showed you examples of that. What proportion of papers describing clinical trials are reported with bias? And I showed you that. What proportion of new drugs fit the ESMO value criterion? How common are drug interactions in cancer patients? These are all things that are based on the literature and on simple investigations that you can do with patients. So these are types of studies that can be done with limited resources in low and middle income countries. So that's the end of my talk. And I apologize that the internet went off, hopefully only briefly, and I'm happy to take questions.
Thank you, Ian, for refreshingly honest